So very good afternoon to one and all.
Good afternoon, Pooja.
Good
Thank you
afternoon.
thank you so much for your precious time on attending the Ivy Talks last edition of 2025. It's been a wonderful full year with all of you, all the INS India members. Thank you for all the encouragement and all the appreciation. I'm Pooja Swarup Saxena. On the behalf of Polymed and INS India, I would like to welcome you to the December edition of Ivy Talks, your own platform wherein we share knowledge, we share expertise, we share experience, and all of us interact with each other, real-time scenarios discussion, everything is here, which is, as INS India members, we all look forward to. So today's session is very interesting. It is a very specialty session, which many of you have requested also during the feedbacks that we collect. So you have specifically asked for a session on pediatric infusions. So thank you, Sharmishta ma'am, for bringing this up from Gujarat chapter. We have the chapter officials, Sharmishta ma'am and Ginny ma'am over there. But before proceeding further, to Ivy Talks, I would like to invite Madhukari ma'am, our own Madhukari ma'am, to flag off the session from the behalf of INS office. Ma'am, over to you.
Thank you, Pooja. And once again, welcome all of you. Hearty welcome from INS India. And I, on behalf of Colonel Binu, the CEO of INS India, would congratulate all of you, those who are present today, and the organizing team to organize such a wonderful program, IV Talks. And today's topic is very essential and crucial for all of us because I think every nurse in the system is facing this challenge of pediatric cannulation. So venous access the infusion access for uh, pediatric cases is a challenge not only for nurses, for doctors and all caregivers. So with that, it is important for us to know, and I think Sharmishta, I thank you for taking this initiative of arranging this IV talks on this such a vibrant topic, which is essential for everyone, whoever is attending. And I definitely feel who is not attending will definitely miss today's session because it is so important, and it is like every one of us want to come out of this challenge. That is also very important. And that's why, I remember that in month before last year, December, by last week of December, me and Pooja over phone, we were planning about IV talks. Pooja, you remember? I was
Yeah,
in the
ma'am.
hotel and I was remembering about that, how to plan about this IV talks and how to make it more effective, fruitful, so that, we can make it more interactive. We can make it more useful for nurses to actually grasp the gist of the topic that we select. And it exactly the introductory session, I was seeing that in my WhatsApp, the introductory session was on 25th January 2025. So it was wonderful day to start with IV Talks, and every month on month, the number of people that they have attended, it is incredible for INS and for Pooja to take this initiative from Polymed. It is a wonderful initiative, Pooja. I really thank you for this because it was not possible without your initiative and your strong-headed, push towards us that yes, IV Talks should be so successful and we should be attending it. We should be getting a lot of knowledge from the experts that are there to present every month on month, and every state has been participating. I really congratulate and thank everyone. So this is a good program and we really wish to take it forward next year also. That's what me and Pooja were talking this morning, and with some more adding to it, value adding to it, so that we can make it more interactive, we can make it more useful for you all, and you really feel that I should not miss this program. It should be that interesting. So with that note, once again, I thank the organizing team and wish all the best to all the presenters today and the new year to come with a healthy life and happy life. A big year ahead. Thank you all so much.
Thank you. Thank you so much, ma'am, for the kind words of encouragement for all of us. It wouldn't have been possible without the constant support of INS India and all the chapter leaders. So thank you everyone, and of course the INS India members. and the Polymed clinical team. They have been on ground everywhere. So thank you. And coming back to the session today, the rules remain the same. Because it's a webinar, it's on the MS Teams webinar. So all the attendees, you may not be able to unmute yourself. So you have the chat box with you for all the questions, all the queries. There is a Q&A box also. So we have our eminent speakers. They would be answering all the questions, all the queries, and we'll try to maximize our knowledge with the help of our speakers. So without much ado, I would like to invite Shamishta ma'am, chairperson, INS Gujarat chapter, and the nursing head at KD Hospital, Ahmedabad. Over to you, ma'am, to take the session forward.
Thank you. Thank you, Pooja. First of thanks to Colonel Vino ma'am, Madhukari ma'am, and the whole INS team, including with the Polymed team, to giving this opportunity to Gujarat chapter. The day we discussed with the Pooja that in the December we have to start the IV talk for the Gujarat, and we were just discussing and we given the topic. Then we select the pediatric access management, and suddenly I meet the Dr. Snehal. I know madam is very passionate in the pediatric management. So immediate I click about the Dr. Snehal madam and I meet madam that we have to give one session about this pediatric access IV management. And immediate madam is ready for this session. I'll just give the brief introduction about the ma'am. Dr. Snehal madam is the DNB pediatrician and done the fellowship in the neonatologist. Madam is a head consultant of neonatal and pediatric intensive in KD Hospital. She is the national simulator instructor, editor Neobies and NNF Gujarat newsletter in 2019 and 20. Madam is executive NNF member in 2022 and 2024. Secretary of AOF Gujarat Women Wing 2025 and faculty for National NeoEQ program and Intech program. Thank you, ma'am. I'll request to start the session behalf of the KD organization and IS team.
Thank you so much, Samishta Ben, and thank you, INS, for giving me an opportunity to present my talk. I hope we are ending this 2025 with a good, good session at the end, and we cater the pediatric age group with unique formulas following this talk. So I would advise everyone to be attentive. And at last, I think for the nursing staff, there is some quiz as well. So I think we can do that with the chat box as well. So let us go ahead with the same. We are ready?
Yes, yes, madam.
Yeah, sure. So my screen has been seen?
Yes, yes, madam.
Yes, ma'am.
Okay, fine. So what we are going to discuss is an IV line in pediatrics. Now, many of you would be agreed that when we are, when somebody has been instructed to put an IV line in a pediatric, the nurses, even the doctors are into a bit anxious situation, because it is not only a simple IV insertion which we do in an adult. Pediatric IV line insertion has its own challenges, and what are those we all know. So first challenge is a crying and uncooperative baby. How good you are, but looking at you and looking at the procedure and looking at any stranger, the baby would be always crying, and baby would not be any time cooperative, even though it is a adolescent age group pediatric child as well. They are not at all cooperative for putting an IV line. Their veins are absolutely thin and invisible, except in some of the pediatric patients. Most of the pediatric patients, if I'm talking about an infants, they would be a chubby babies. So it is very difficult to find the veins in them. And then to hold and restrain this crying and uncooperative baby is a big, big challenge in front of a panic parents. And because of all this thing, crying babies, veins are not visible, parents are aside and they're asking multiple questions, the staff gets anxious. And this whole combination leads to a procedure like simple IV cannulation into a big surgery kind of a, situation. So that let us, let I have tried and discussed some of the important things which we should do as a pediatric IV can to make this pediatric IV cannulation easier day after. So basically, let us understand what are the indications for pediatric IV cannulation. Again, I would, request that if it is possible with an oral medication, these are the base drugs to offer in, like in an admitted patients as well. But if the IV cannulation is necessary, we should go ahead with the same. And we know that the indications are to administer the fluid intravenously. We know that the maintenance fluid requirement would be there in a child who is coming with a fever. They would be dehydrated. We should give an administer proper amount of the fluid to maintain the IV cannula as well, to administer the IV medication. So cooperation of the pediatric patients for IV medications and oral medication would also be would always be poor only. But some to have an IV medication insertion, we should have an IV line inside in situ. To administer the blood products, sometimes we have to administer the PCVs, FFP, platelets, and for that a good size cannula should be there in situ to administer this product. Fourth, to provide access for the diagnostic procedures like, when the pediatric patient is going ahead with the procedures like, CT scan or MRI, if we want to give in contrast, then for dye injection as well, we have to have an IV cannulation. Which are the areas in a pediatric age group we should avoid IV cannulation? So already if you're feeling that vein is hard and sclerosed, don't go ahead with that vein. Areas of flexion where the baby has to move the limbs and at the if you can see at the time at the wrist, at the elbows, you should avoid putting a lines. Fractured limb, again you are not supposed to put in a line on that area. Veins in the proximity of arteries. So again, we are very much fond of putting a vein at the dorsum of the wrist, but you have to take care that if you are taking a volar aspect, there would be a chance you may prick the radial artery as well. So you have to be careful for the same. In extremities where arterial cannulation has been done, so sometimes in a critical PICU patients, we have an arterial line in situ. We are giving, we are measuring the invasive blood pressure of this babies. So in this patient, in this extremity, you should avoid putting an IV cannulation, venous IV cannulation. And if you have already history of a previous thrombosis in that arm, avoid that area. Now we all know for pediatric IV cannulation, pediatric age group is, it's a whole age group and it's a growing age group from 0 to 14 years of age. And different sizes of the babies are there with us. And for that, we have a different sizes of IV cannulations. So we all know the marks and the color coding. 26 goes here is an orange, but ideally we are getting 26 is a purple colored cannula, which we are using in the neonates. 24 goes also we are using in the neonates. 26 goes are we are using in the patients who are like extreme preemie babies. We are using that.
Ma'am,
22.
Dr. Snehal, ma'am, the slides are not moving according to what you're saying. Yeah, now it is correct one because there was some, it was not moving. Some feedbacks were coming from the groups.
Okay, fine. Is it all
Yeah.
right now? I mean, I'm
Yes,
talking about the cannulation sizes and so
yes. Now
yeah.
it is okay, ma'am.
Okay,
Sorry.
fine. Yeah. So for the different kids, like for the neonate, you want a smaller size of a cannula. For adult kid, you need a bigger size of cannula. And again, the cannula size will differ as per the vein sizes. So if the vein is thin, you may have to go ahead with a smaller cannula in that patient. But to give a products like blood products to give a contrast and all, you should have a bigger cannulas in situ. And then we know that we have a saphenous and we have a cephalic vein to be inserted with a bigger cannula, so that we can have a good access for the blood products and uh, dye injections. Now, these are the most common sites of an IV insertion. Mainly preference would be the palm, and that should be a dorsal of the palm. And we know that our most favorite is a cephalic vein. And most of the time, you feel that it is relatively easier, even though the baby would be chubbier. It is relatively easier to put in this vein. So you have both hands, and you can find out tributaries of the cephalic vein in the both hands, and you can pick up any to go ahead with the same. The second option to us would be the radial. Again, I would say we would differ, because molar aspect would differ to put in a radial for the proximity of the radial artery, but we can always choose a cephalic vein. Our cephalic vein should be distal to the elbow, would be a preferred one, rather than near to the elbow. Again, the flexion of the extremities would be a problem with that. But when you are not getting access, then you can go ahead with the same. The legs would be a third site of a preference. Again, you can use a dorsal plexus tributaries. And if you want good large bore vein, then the great saphenous vein would be a good option for the same. And in infants, not in a
Excuse me, Dr. Snehal, your slide is not moving.
my slide is already there with the. Am I not able to show the vein?
Right now you are saying about the different sides of the
Yeah.
cannulation.
No. I'm saying about different peripheral vein access sites. So I'm
Sides.
talking about the veins. Huh? I'm talking about the different veins. I'm talking about cephalic, saphenous, and all these veins.
No,
So
no, that the slide is showing the venous cannulation in pediatrics,
Cannulas
IV cannula
only.
size, color, and use. That is
oh
showing
no
in
no
the screen.
no
Right
no
now,
no.
it's a pediatric AV.
Again,
No,
I am
same
there.
same slide is there.
Oh, okay. Now,
Now, the anatomy of the hand palm is there.
yeah, that is what I was discussing.
Yeah.
But I've already done it, I think 3 minutes back when I started, talking about this.
Yes, but the slide was not moved it.
Oh, okay. I'm sorry about the same, but I don't know what is happening.
And your voice also a little bit husky.
There is some network
Ah,
issue.
now it's clear. Now it's clear.
Is it clear now? Okay, fine.
Yes,
That's
yes,
great.
yes.
Yeah, fine. So
Thank you.
we discussed about the access of the vein in pediatric age group, the different peripheral sites where we can insert the vein. Now, sometimes in an infant who is like, the infant, the babies who are less than 1 year, we can go ahead and put the scalp veins as well. But again, I'm saying it's getting very crude method for inserting the scalp vein. But when you are not getting any access, then you can go ahead with the same as well, and it is very prominent. They have been very prominent in the forehead, or like the in front of ear as well. And occipital veins are also been very nicely seen in the infantile age group. So if you are not getting any access, or if you have been exhausted within peripheral venous access, then you can go ahead with scalp vein insertion in this pediatric age, in the infantile age group as well. So these are about a, but again, I would suggest that there should be a supervision of a doctor when you are planning to put an scalp vein, because your AF would not be closed, and you may enter, like, if you're going to centrally, you can go into a choroid venous plexus as well. So it should be under supervision of a doctor, or the doctor should be ideally inserting the scalp vein. Now, are you able to see the next slide, this slide, IV preparation?
Yes,
Yeah,
yes,
okay,
yes.
fine. Sure. Okay, fine. So, pediatric IV cannulation, or any, per se, any IV cannulation, the preparation is must. So, sometimes there would be a staff who would be there to put in a line, but then they would, after putting a line, they would realize there's no flushes available, the dressing is not available, then the extension line is not available. So that would be a always a chaos. So please make sure that you should have an IV line tray in your unit, and it should be followed. And again, when you are carrying an IV line tray in a pediatric, you should have a different cannulas for that age group available. So you can have a 24, 26, 22 gauze cannulas available with you when you are trying to go ahead with the IV line cannulation in a pediatric age group. So most important thing is you should have a sterile tray. Sterile sheets are most important. Now what is happening, when you are putting the IV line, you are touching the surroundings, and then you're making that area aseptic. So putting a sterile sheets or towels is must when you are going ahead with an IV line cannulation. Pediatric veins, as I said, would be a thin and undetectable, so you can use a vein detector with you at that point of time. Alcohol swab is an easier and most comfortable antiseptic solutions for the IV line insertions, rather than going ahead with the chlorhexidine and all, and they are readily available. So I would ask you to go ahead with the same. IV cannula of the different sizes, Q size or extension tubing should be available. This Flux or any kind of pre-filled normal saline infusion injection should be available with you. Tegaderm, there are different tegaderm sizes available as per the kit's size, and then you can choose accordingly. Most important thing here, which is missing in this picture as well, is a splint. So after proper IV cannulation, the splint is most important for immobilization of that area, because kids are moving their extremities frequently, and there would be a chance of extravasation, and that's why fixing with the splint is most important. There are different type of splints available, different sizes of splints are available, and you should use all of them to stabilize the IV cannulation of the pediatric. Again, labeling is most important when you have inserted a cannula with the time, because you should have a IV cannula insertion. You should have a removal guidelines available, and then in our units, removal guideline is for 72 hours, but differ. But it should not be extended beyond 72 hours, and that's why it is important to label the IV cannula. I hope you must be doing all this practices in your unit. Let's go ahead with the parts of IV cannula. There are different upgraded versions of the IV cannulas as well available now, so that you can avoid having a spillage when you are withdrawing the stillet of the cannula. So you can use those IV lines now. These are all the parts. I think you all are aware about the same. I'm not going in detail of the parts of the IV cannulations. Most important thing over here is for pediatric IV cannulation is explanation. The challenge is, the first challenge hurdle I'm explaining it to you is explanation of the parents, and preparation of the parents is most important before putting an IV line. So you have to take the parents into a confidence that this procedure is safe, and after insertion there won't be any pain or discomfort to the patient. It is only the plastic cannula who is there inside. There would be there in situ. There should not be. There is not going to be a stillet inside which will cause continuous pain to the baby. So you have to take into confidence the parents first, and you have to explain them this is what is an indication that your child might get dehydrated, or without IV medication the child is not going to improve. You have to explain why the IV cannula is necessary to the parents, and then go ahead. Sometimes when they are convinced nicely, they would act as a good restraint for the baby, so that sometimes you can ask the parents to be with the baby when you're putting a cannula. They can calm and compose the baby at that point of time, so that you may not require many restraints. Otherwise, what happens, there would be 4 or 5 people who are there to administered a pediatric IV cannula, and there would be 2 or 3 people would be restraining the baby. Baby would be crying. The parents are outside. They are also yelling, what is happening inside with my baby. So it is better to allow the parents with the baby when you are putting an IV cannula. and take them into a confidence. Now, IV cannula insertion consent is ideally not required. In the medical legal area, everybody is asking about the consent for each and every procedure. But for IV cannulation, when the patient is admitted and you have decided to start with an IV administration, IV drug administration, that is an implied consent of the parent side, that you are going to start with an IV medication, and for that the consent is not required, but the explanation is important, and we have to explain the parents that how long the cannula would be remain in place, and then you have to explain possible complications as well, so that they would be vigilant, there is something happening to at the cannulation site, and they will let you know the things immediately. So that is important. Now, for pediatric IV cannulation, what is the procedure? Again, after explaining the procedure to the parents, you should be having a aseptic techniques for insertion of the IV line. So first of all, you have to identify the vein, which vein you want to insert, and then you have to check for the indication of IV cannulation. Now, doctor has written an order of giving an FFP or a blood product. So then you can think that, I have to go ahead with a large bore cannula in this patient rather than a small bore cannula. So you should be knowing the indication first. Then use appropriate size of cannula as per the age and procedure. You have to have an aseptic techniques. Identify the patient using to identify. You have to you are using the patient labels and everything, and you have to take care of the same. Ensure the patient is in a comfortable position when you are putting a cannula. My slides are going as per my talk, or it's like it's still lagging back? Hello?
Yeah, it's
Yes,
moving,
madam.
it's moving.
It's moving, no?
Yeah.
Fine, perfect. Now you have to make sure that there is an adequate light. So you're not operating the patient, but you have to make sure that there should not be a congested or a dark place, and too many people are not sitting around or standing around you when you're putting the cannula. This things matters a lot. So you have to have an adequate light over there. You have to check the site and accessibility of the veins, and sometimes parents are very very clear that we don't want to put in a cannula into the legs, or they are very clear that okay, we want to have a cannula in the left hand only because right hand we want free. So if it is available, you have to take into a consideration of the parents concerns as well. Always use a vein from the distal part of the hand, so that a proximal vein can be used later. This is very important. So again, we are first preferred site we discussed as a palm that should be used. Ensure the cannulation site is free from any hair, but that is actually not there in a pediatric population much. Spread the sheet protector to avoid any soilage. Apply the tourniquet around the patient's arm above the intended cannulation site. Sometimes, you may omit this step. You can just use your opposite hand or other person's hand to, compress the venous site, and then you can have a popping of a vein. Stabilize the vein using your non-dominant hand and apply traction in the skin distal to the chosen site of an insertion, and this will prevent the superficial vein from loading away from the needle. So this is again very important, especially in the patient who are not chubby and who are having a lax skin, especially the dehydrated patient. And if I'm talking about extreme low birth weight babies, in those babies, skin would be little lax. The subcutaneous fat is not been well developed. So there would be, when you're not giving a proper traction or stretching the skin side, the laxity will cause the vein to roll over. So then you have to take care of this aspect properly. Swiftly insert the needle through the skin, bevel side up at 15 to 30 degrees with the skin to the lumen of the vein. Then in the backflow chamber, you can see the blood which is coming. And then when it is coming, you just pull a back of needle of at least 1/4 from the tip of the cannula, so that you are not going inside the posterior wall of the vein. And that will prevent the counter injury to the vein, right? So you have to advance the cannula of the after retracting the needle a bit, and then you advance the cannula in the vein carefully to prevent puncturing the posterior wall, as I discussed. If there is a tourniquet, you may release the tourniquet. You have to flush the cannula with the normal saline Possiplex solution available at that point of time. And again, it is very important when you are removing the tourniquet and there is a catheter is in C2, you have to press the catheter properly, otherwise there will be spillage of the blood which is coming out. Secure the cannula with a transparent dressing and mark the date and time of cannulation. Administer the medications, IV fluids or blood as per the prescription. You have to check the orders of the doctor properly. Ensure patient is in safe, comfortable position post procedure. So there should not be any pain when you are administrating the IV fluid. So as soon as sometimes we come up with the issues like that. As soon as the IV cannula has been inserted, fixed, but after that the patient is complaining, the baby is constantly crying, or is complaining that the at the local site he or she is having extreme pain. So you have to make sure that when you're flushing the normal saline through the IV cannula, you have to make sure that everything is in C2 properly and there is no extravasation of the medication which is happening. Check for the comfort of the arm in which you have inserted the cannula and replace articles and dispose the waste as per the policy. This all, I think, you must be doing 100 times a day. But sometimes some mistakes can lead to a major issues. That's why I have discussed this whole procedure in detail so that you're not missing out on any aspect. Remove gloves and wash hands, document the procedure, and look for the signs of a phlebitis, infiltration, hematoma, extravasation as per the VIP score. I know you must be knowing the VIP score in detail, all of you. 72 hours is the upper limit for the cannula to be kept in C2, and change the cannula if there is a discomfort and a pain persists, and follow the hospital policy for the turnaround time. Again, I'm telling, in my hospital the turnaround time for the removal is 72 hours in my ICUs. So this is the whole procedure I have explained. Selecting the site is most important. Then clean the site with a disinfectant solution. Applying tourniquet, again I'm saying you can skip this step and you can just have a firm hold handing. Then needle insertion. You can see the blood return through the cannula over here. Then advanced introduction of the catheter with needle in C2, right? And then when you are sure enough, you are just putting the needle out of the cannula. You can release it on a tourniquet if you have applied that, and then you have to apply gentle pressure of the vein at the catheter tip when you are removing the stylet, so that you are not causing a spillage. And after that, flushing the cannula and fixing the cannula site is most important. And over the tegadum nowadays, there is a date mark is available. So you can write down the date and time where you have inserted the cannula. So for a pediatric cannulation, there are some do's and don'ts. And we should keep in mind, when we are dealing with the pediatric patient's cannulation. So first is, as I told in the second slide itself, there are some safety cannulas available so that they can be used, they can be reused, but they are very good for preventing the needle stick injuries. Pre-operative patients, usually left arm is preferred. So for an anesthetic, it is easier to move around. But again, you have to be careful. Sometimes if you are going to operate on the same extremities, you have to avoid the same extremities. And yeah, remove the cannula if there is any redness, swelling, and discomfort is reported. Remove the cannula before discharge of the patient. This is again very important. There are units which do continue with an IV line medications or IV antibiotics on OPD basis with cannula and C2 at home, and this practice should be highly discouraged. because there would be a chance of an inflammation, phlebitis, there would be a chance of an inadvertent drug injections by parents. So you have to make sure that whenever you are deciding the patient, especially the pediatric patients, you have to remove the cannula. The patient should be on oral drugs and taking the things orally. Except for the chemo patients, again, you have to make sure that your chemo pot is, properly secured, or if there is uh, glans catheter which has been inserted, that also been, properly closed and secured. So what are the dons? Do not puncture the arm with an AV fistula or shunt or lymphedema, burns or a surgery, as I discussed. AV fistula usually, it's very rare in a pediatric patient. But again, if I'm saying that, if there is a chemo pot inserted on the right side, so right brachiocephalic trunk, I would ask you to avoid the right extremities for putting an IV line. You have to go ahead with the left extremities. Do not use Dynaplast for securing the cannula. We have a nice diagrams available. They are transparent dressing. So any kind of edema or a redness would be visible very immediately to you, and then you can take care of removal of this cannula. Do not forget to remove the tourniquet at insertion site. Very important. And sometimes, people are very enthusiastic to compress and to apply the tourniquet. Uh, and then sometimes that lead to a arterial constriction as well, and that will lead to problems like thrombus and all those kind of an event. So I would advise to be careful when you are using a tourniquet. It should not be very tight. It should just restrict the venous return, not the arterial pulsations. Do not repuncture using the same needle in case of a difficult access, and do not apply tourniquets too tightly. These are the don'ts. Now, I know you must have been seeing some of the complications of an pediatric IV cannulations, and these are happening in the wards when we see the pediatric, and the parents are very much apprehensive about this kind of a complication. Some type of an edema or phlebitis we see, we find it's like it's very normal, but for the parents it is a big issue. And sometimes, it can lead to a big medical legal issues for the staff and the doctor as well. So we have to be very, very careful. And that's why the IV cannula maintenance or IV cannula assessment should be done at least second hourly in a pediatric age group. So your VIP score should be checked every second hourly in a pediatric age group, and this is a norm. So this, what are the complication? Mechanical phlebitis. Mechanical phlebitis is what? This is associated with the injury to the tunica intima. What are the, how many layers of the vessel walls are there? Tunica externa, media, and intima. So when tunica intima, over the tunica intima, your cannula is there and it's constantly irritating, right? And that's why it will cause a kind of a phlebitis. So if your vein, sometimes we say that, it is a positional vein. So what is happening in the vessel wall, here at the tunica media, tunica intima, your cannula is like this, and that is constantly irritating the inner wall of the vessel, and that's why you may end up with the redness over that area. And we see that, the staff is checking the vein and they are seeing that no flow to barabar jai chhe, yeah, flow would be going properly, but there is a constant pressure which is causing a pain to the baby, and that will end up with the mechanical phlebitis. Now, what is chemical phlebitis? Again, it's an injury to the tunica media by solution infused to the venous system. This is again very important. So for a pediatric age group, I think, when all of you must be using the volumetric pumps or infusion pumps when you are using when you are giving IV fluids to the babies, right? So sometimes the dilution of the drug is not proper, then you can end up with a chemical phlebitis like that. So, simple injection, simple antibiotic like ceftriaxone. If the ceftriaxone is given to the baby, you see that, whenever you are giving the ceftriaxone, they do cry at that point of time. So you have to make sure that there should be a proper dilution, at least sometimes 1:10 dilution of the antibiotic solution should be there, so that there should not be a chemical phlebitis to the babies following this kind of an irritant injections. Again, simple febrile paracetamol will also cause an extreme pain, because it again irritates the inner layer of the vascular wall. So that the paracetamol injection should also be properly diluted before giving to the patient. Infective phlebitis. So this is very very important, and I would like to ask you at the end, how many of you are using gloves when you are handling the IV lines? And if you're not using, it is must, because even though we are washing the hands, there's sometimes cross contamination, and we know that the health care providers are the maximum source of a transfer of an infection to the patient, and most common site of an transferring the infection is an IV line. So if your IV line maintenance is not good, then you are transmitting the invasive infection to the patient, and then that will lend to a sometimes life-threatening complications as well, life-threatening infections as well, especially the babies who are being immunocompromised, the babies who are very sick, the babies who are in the ICUs, the babies who are prematurely born. So you have to be very careful when you are using the about your aseptic precautions and hand hygiene when you are dealing the IV lines of the patient and otherwise as well. So if your hand is contaminated with some kind of a bacteria, and then we are knowing, staph aureus is most commonly transmitted like that. But now we are more worried about not a staph aureus, but we are worried about an MRSA. Many of the staph aureus and medicals in hospital setup are getting resistant, and we are getting many more strains of a MRSA. And this is a bad infection to be carried forward. So you have to be make sure that you're taking care of a proper hand hygiene when you're dealing with an IV cannula. If it is not been done properly, there would be a bacterial transmission from your hand, from the surroundings of the patients, and then there would be a bacterial lodgement inside the vein. Sometimes, if it is local, it will just cause a local phlebitis. But sometimes it may land up with a severe bacteremia and a sepsis in this pediatric age group. So you have to be very careful about the same. Cannula occlusion, that can be the cannula is either partially or completely blocked. Sometimes the IV fluids, which when we are disconnecting the IV fluids of the patient, there is not a constant flow, and there would be a blood clot, and after that when we are flushing, the fluid is not going. So this is a cannula occlusion, and to prevent that, we should have an heparinized solutions available. So whenever we are disconnecting the continuous IV fluid, it is advisable to cat flush this IV site, and then lock it, so that there would be a less chance of a occlusion on this to this area. Infiltration. This is inadvertent administration of non-vesicant medication or solution into surrounding tissue, and this is what happens. So I had couple of patients from the peripheries who are being given an calcium gluconate through the peripheral vein, and this patients have developed very bad, hard type of a swelling, because there would be an ossification of that area, and that infiltration would be very bad, and it takes months of it to go properly. So we have to be very careful when we are not sure the cannula is inside. We should not flush any of the injections into the cannula. Now, again, with that, I would like to talk about some injections which should be given very slowly in the pediatric age group. So, in a neonate, if there is a pediatric nurses available over here, they would be knowing that in neonate we are giving a maintenance calcium to the patient. Normally, that maintenance calcium has been added to the drip, but sometimes that is asked to give an IV as well. Now, if you are giving that calcium not as per the norm. So ideal norm is calcium solution 1:1 dilution slowly over 30 to 40 minutes and through the infusion pump. But if you are not following the same, and if the calcium injection is being given faster to the child, then what will happen? There would be a sudden cardiac arrest and you would not be able to revive the child. So you have, it's simple calcium injection. So you have to be very clear about drug administration procedures as well into the patient. Now, next is extravasation. There is inadvertent administration of vesican medication solution in the surrounding tissues. Have you known? Have anybody is known about purple glove syndrome? Anybody is knowing that? So what is this purple glove syndrome? Purple glove syndrome is an extravasation of a phenytoin. So initially, when right now the first phenytoin is available, but that is fosolene. But if you are talking about an apsulin, if it has been given and there is an extravasation of the same, you may land up with the purple glove syndrome, the severe venous congestion of that limb, and sometimes you may have to go for an amputation of that limb as well. So you have to be very careful when you're giving such kind of an high alert drugs to the babies. Hematoma that is associated with blood linking in the vessel wall, that has been expected sometimes. So these are very important markers of your IV care. Okay. And if any of this has been routinely present, then we have to make sure that in our unit there should be some uh, protocols or SOPs needs to be made or to be followed, so that these complications can be minimized. Pediatric IV cannulation VIP score, I know you must be knowing that, but still I'm revising it. If this VIP score is 0, that means your IV site is absolutely healthy. You have to continue observing the cannula site. Now, for the one of the following is evident. It may be a slight pain over the IV site or slight redness over the IV site. You have to, take it to a caution. If you are observing it every second interval, then you have to observe it every 1 hourly. Whenever you are flushing, you have to check for the any redness is increasing or not, or edema is increasing or not. Then if the score is 2, then you have two things which has been there. That is a pain, erythema, both. So if you have pain, erythema, or swelling sometimes, then you have to remove that cannula and you have to reinsert the cannula at somewhere else. Then if the score is 3, that means all of these are present and evident. That is pain at the part of cannula, erythema, induration or palpable venous cord less than 5 centimeter above the IV side, IV side, then you have to resite the cannula in this case. The fourth is like your frank phlebitis. If you have all the signs evident and extensive, so pain, erythema, induration or palpable venous cord more than 5 centimeter above the IV cannula site, you have to resite the cannula and you have to take care of the local part as well. You may apply a local antibiotic cream like mupirocin and all over that site, and you have to check for swelling which has been increasing or there is any discoloration on that area. Then if the score is 5, there is an associated fever. Now it is an associated fever, so it is not a local infection. Your phlebitis has caused a bacteremia as well, and then you have to consider a treatment, sometimes IV antibiotics. So you have to learn this VIP score properly, and that should be properly documented in each and every patient. Okay. Now, what are the rules of an IV administration? There are 5 rules of an IV administration. One is right patient, then right drug, then right dose, right route, and right time. I would talk about an incident that where the fluticasone nasal spray was being given orally to the patient. Okay, and Enterogermina respules was being given IV to the patient, that has been reported to us in one of the meeting. So this kind of a mishaps can occur if you are not taking care of an order properly, and for that legitimate prescription orders are also must. And that's why, nowadays more and more many of the hospitals are acquiring the softwares, so that there should be an order which can be written down in the computers, so that there should not be a medication error. There are some drugs which are allied drugs. They would be looking like just same, and sometimes you can um, mistakenly given the giving the opposite drug. So you have to be very, very, very careful. Some drugs are coming with a different concentrations as well. So midazolam is coming as a 1 ml 1 milligram solution, and 1 milligram 1 ml 10 milligram solution as well. So when you are giving the injection, you have to make sure that you are properly checking the formulations as well. So the concentration of the drug also is very important, and you have to get it rechecked by the doctor when you are in doubt for the same. Yes. So after putting an IV line, you have put an IV line, you have secured a nice cannula, you have done the proper dressing, you have done splint over that, you have put in an extension line, you started with the IV fluids to the patient. Now maintenance. Now maintenance is very much important. So whenever you are going to give a drug to the patient, first thing I would advise that uh, use at least two line Q sites for the pediatric patient, so that one line can be your continuous IV fluid, and the second line you can use for the medication administrations, like the supportive medication in the form of paracetamol or Nencitron and antibiotics. So you do not have to disconnect the IV fluid at that point of time. And again, in a pediatric age group, in our unit, we are making sure that we are using infusions, and we are using polymetric pumps for fluid in administration as well as for medications. So I would ask all of you to follow the same for the pediatric patient. It is, pediatric patient, the fluid concentration is also very important. If you are giving too much of an inadequate volume, then it will lead to a cardiac overload to the pediatric patient, and you will not realize that. And sometimes, if the proper volume has not been delivered, then also it would be a problem, especially in the patients like dengue patients and all. So please use a volumetric pump that will give an accurate idea. And if there is any occlusion or any problem to the pump, you are knowing that you have to, there is either a partial block in the cannula, or there is a site problem. So if there is any obstruction in the infusion pump, you have to address it immediately, so that further complications can be avoided. Hand scrub is most important when you are going to touch an IV line of the patient. Wear gloves. Wearing gloves is most important at that point of time. अभी भी नहीं हो रहा है वो?
No, ma'am, it's showing. Now it is okay.
Okay, fine. Wear gloves when you're handling the IV cannula and IV cannula. Check medicine and prepare the medicine properly. Again, hub of the cannula or an extension site should be cleaned each and every time when you are going to administer any of the medication. So you have to, if you manage the peripheral line just as good as in a central line, there would be very, very less chance of the phlebitis over that area, and that very less chance of transmitting the infection to the baby. Scrubbing the IV hob with the alcohol swab or 2% fluorhexidine solution is must. Administer the patient a medicine in defined time. Check the dilution with the doctor. Pediatric patient, IV fluid should be given through the infusions only, that I all have discussed. Pump pressure is also most important. Sometimes, most of the time, the pump pressure has been decided by biomedical engineering engineers, and then it has been pre-decided. We have a different type of different companies available for the pressure pumps or volumetric pumps or infusion pumps. Uh, but if you are giving an increased viscosity of the fluid, or the rate is high for the pump, this thing defined pump pressure, or the diameter of the IV cannula is smaller, and you are giving a higher volume, then also you may find, occlusion over that area. Increase occlusion alarm in that pressure pump. Then increase length of an intravascular catheter. So sometimes we are putting a PICC lines in this pediatric patient, that is peripherally inserted central venous catheter, and these lines are not going actually. We are not going through actual central this thing, but from the peripheries we are going to the central lines. So when you are using it hand, we are going to the subclavian. When we are using the saphenous, and then we are approaching the internal iliac as well through the femoral. So, and those lines are extremely long. They in a preterm babies, when we are inserting, they are like 12 centimeter, 15 centimeter, or 20 centimeter long. And when your flow is not proper through the long line, that would be a problem of an occlusion, and then you have to remove that line. So you have to be very careful when your PICC line is in C2 and you are not giving enough of flow to the patient. And if there is a continuous increased level of patient activity, then also you may find an occlusion alarm in your infusion pump. So this all can be taken into consideration, that if there is an occlusion alarm, and if the IV cannula is in C2, and it is going flushing properly, then you have to take in care of these considerations. Flushing or locking the lines, it is must. Whenever you are disconnecting any infusion, you have to flush it before inserting any fluids. Then you have to flush the IV site. Immediately after the placement, you have to flush it. Prior to and after the infusion, again, because that would be back pressure, and that would be a blood reflex, then you have to flush it prior and after blood drawing. These are very important and a basic aspects, but it is must that we are doing it properly, so that we can avoid any inadvertent complications to the patient. Uh, so I'm giving you one simple role of a maintenance fluid, or some simple formula of a maintenance fluid to the pediatric age group. So whenever you have a patient, you just calculate with the 4, 2, and 1 rule. So 4 to 1 rule is what? Like if you have a patient who is like less than 10 kg, your hourly fluid maintenance would be 4 ml per kg per hour. So say the weight of the child is around 5 kg. So you have your infusion rate should be 20 ml per hour. That you have to manage, and roughly it should be around 100 ml per kg per day. Now, if your baby is 10 to 20 kg, then it is 40 ml. You have to continue, but then that is for initial 10 kg, because it's a 4 ml per kg. So initial 10 kg would be 40 ml, and then for the rest 10 kg, it would be a half. So that should be 2 ml per kg 2 ml per kg per hour every hourly for more than 10 kg. So it's like that. So for initial 10 kg, it would be 1000 ml, and the rest 10 kg, it is 50 ml per kg per day for every kg over 10 kg. Now for 20, more than 20 kg, we know that it is like 40 plus 20, 40 plus 20, then it is 60 ml, and then half of that, that is 1 ml per kg for more than 20 kg. So if you are using this formula roughly, you can know the maintenance fluid of each and every child. Though it may differ sometimes in a dehydrated patient or in a dengue patient, doctor could have asked you to give a higher infusion rate of the child, but this is a rough calculation, and you make sure in an infusion you are setting it properly. Most important thing is beware of inotropes. So any inotropes, except in an emergent situation, the patient is going into a sudden collapse and you are not having a central access at that point of time, you can give an adrenaline push to the peripheral line. But ideally, if the patient is sick and it is required to start with an inotrope, central line must be in C2, so that you can deliver the drugs properly into the circulation, and then you are getting the good outcomes for the same. But if needed, then sometimes adrenaline or non-adrenaline, you have to start with the peripheral line. You have to make sure that you're using a double dilution of the same. So if it is 1.2 ml you have to dilute in a 24 ml of solution, then you have to make it 1.2 ml, and you have to dilute it in a 48 ml of R, and then you can adjust the ml per hour, 1 ml per hour rather than 0.5 ml per hour over here. So you have to make the dilution likewise, so that you are not causing irritation of the vein. Because if you see at any point of time, if you have given a vasoconstrictor like adrenaline or noradrenaline or a vasopressin to the peripheral line, you must have seen that limb will get ischemic or a cold, that extremity will get extremely cold, because there would be a surrounding severe vasoconstriction of that vessel, and again that drug will not be delivered to the circulation properly. So you have to be careful when you are using peripheral lines for the inotropes. Now, if everyone is ready, let us go ahead with the questions. Sharmista Ben?
Yes, please have any
May I
question,
go, may I go ahead with the
please.
questions? Yeah. So the couple of questions. The most common complication of IV calculation is in children is infection, thrombosis, extravasation, or air embolism. Later on, we'll see at the chat box.
See, one has mentioned C.
One has mentioned C, extravasation. Yes, right. So extravasation is the right answer for the same. Second, best method to secure an IV cannula in a child is tight adhesive cap, splint with transparent dressing, cotton bandage, or leaving the site uncovered. What is the best method?
Ma'am, only question number 2 is visible, the complication one.
Okay. Is it visible now?
Yes, now it is visible.
Yeah.
Yes.
Some problem with the switching over of the slides, huh? So again, I'm repeating the question. The question is, best method to secure an IV cannula in a child is
Someone mentioned B. Chat box majority is B, madam. Hello. There. Hello.
Ma'am, you are muted, ma'am.
Hello.
Snehal ma'am, we cannot hear you. I think she's reconnecting. So there is some connection issue at ma'am's end, so please be there. She'll be back shortly. In the meantime, one important announcement. After the session would be completed, Shinoj would be sharing a feedback form link in the chat box. Please do complete that so that, and in that we would be looking for more topics which you want to be completed in next year's IV Talks. So topic suggestions, it's an open forum for all the members.
Yes. Next time you may allow the member out of the INS also. I mean, today also people were asking, but we have involved, I think, only INS member.
Yes, ma'am. So next year onwards, it would be open for all. For INS India
Right.
members, it would be a complimentary session. For non-INS India members, there would be a minimum cost which would be involved. Not more. It would be a
Right.
minimal cost, very minimal, and that would be floated shortly once in the INS IV Days webinar. We'll be showing that also.
Right, right, right. That's great.
Vaman, can you check with ma'am?
Next, maybe,
Ma'am, you were saying something?
yeah. I mean, I was just thinking the next maybe we'll give the responsibility to Baroda team. Jeannie,
Yes.
Yeah, yes, ma'am. We are also would like to do one conference. Yeah, it's open hall conference in Baroda because so many members are there in Baroda. Mainly in my institute, also more than 70 members are there in INS. So I think they are sitting in my
right,
conference
right.
hall to seeing and listening all this talk. So bulk of team are there in my
Mm.
conference hall.
Right, right. Great, great. And we may give you the Baroda team.
Yes, ma'am.
It may be in around June, July.
Yeah. Somebody is asking, is there is any INS chapter in North? In every state, we are also would like to start one chapter, but all of your contribution is also required. Your interest is also required. We are there to help you.
Which place they are from?
I don't know that this is some chat box. I have seen somebody is asking, is there is an INS chapter in North? I hope you are also saying.
Puja,
Pooja, you can see I am from Chandigarh. Yeah, one Miss Poonam
Chandigarh.
is asking. And Poonam, your mic, you can unmute your mic. Oh, so Pooja.
Puja.
Yeah.
Yeah.
Yeah. So yes, Punjab chapter is live. We have INS India Punjab chapter. Uh, you can Poonam, maybe know from which hospital you are. You can be in touch with Miss Niketana. She is the chapter chairperson from Fortis Mohali, and Miss Shirley. She is from Max Hospitals Mohali. And Miss Daljit, she's also the co-chair. You can also get in touch with Ma'am Daljit also. So yes, Chandigarh has a chapter.
That's great to show interest of the people.
Yeah, we are expecting more people in INS because many more nurses are there. They are also not aware about the importance of INS and all
Yes,
these
yes.
learning sessions are there. So many interesting sessions are there. So many knowledge sharing sessions are there. So many platforms are there to explore you. So all of you need to discuss with
Right,
your
right.
chapter champions and it's mainly the chairpersons who are working there in your state. It is very welcoming sessions. We are there.
तुम अपना रिवर्स कैमरा ऑन कर लो मैम दिख ही नहीं रहे मेरे को actually some issues there. Vaman is switching on from ma'am's side. He's with ma'am only. So we can have the Q&A because we were waiting for ma'am only. Vaman?
Hello.
Yeah, ma'am,
Yes,
we can
madam.
hear you.
Hello. Sorry, I'm
Yes,
joining
madam, we are hearing you.
from some other device.
I'm joining from some other device. And still my screen is not shareable.
Yes, ma'am.
Yes,
Hello.
madam.
Yeah, sorry.
madam.
Sorry for the inconvenience. Yeah. So this question was the best method to secure an IV cannulation in a child is a tight adhesive tap or a splint with transparent dressing, cotton bandage, or leaving the site uncovered. May I expect the answers? Can I see the chat box?
Yeah, chat box there's maximum for the B.
Okay, splint with transparent dressing, that is the right answer. Then the third,
Yes.
which child is at highest risk of an IV infiltration? School-aged, child receiving antibiotics, sedated or unconscious child, and child on oral fluids. What is the answer we are getting over here?
Question is not asked yet.
Which child is at highest risk of an IV infiltration? A, school-aged child, B, child receiving antibiotics, C, sedated or unconscious child, and D, child on oral fluids. You can just simply type
think
A,
B.
B, C, D, whatever is your answer.
Chat box is showing B.
Perfect. Right or wrong? No, it's wrong. Okay. So the child, we are giving IV antibiotics to each and every, most of the patients. And but that is not the right reason for having an IV infiltration because the sedated child and unconscious child, you are not having any complaint of a pain in that patient. So that patient is highest risk of getting an IV infiltration, and you have to be double careful when you are using the patient who has been IV cannulation in a patient who has been comatose, or in whom you have started sedatives like fentanyl or morphine or any kind of this kind of an agent, or it would be neurologically impaired baby. So the answer is C over here. Which vein is commonly used for emergency IV access in children? A, basilic vein, B, cephalic vein, C, femoral vein, and D, scalp vein. What is the right answer? Emergency IV access in children. Basilic, cephalic, femoral, or scalp? What is the maximum answer we are getting, Sharmishta ma'am?
It is for B.
B is a cephalic vein. No, it is not a vein which is being taken into an emergency situation, because in an emergency situation we want a very wide bore this thing. An emergency situation is what the child is in shock. So when the child is in shock, your peripheral veins are absolutely collapsed. So you are not able to insert the IV cannulation in this peripheral vein, and you have to take an access of a central vein at that point of time. And most easy central vein access on a pediatric patient is a femoral vein. So you have to go ahead with a femoral vein insertion in an emergency situation. So when you want to resuscitate a child who is in a shock or in a hypotension, then you have to go ahead with a femoral vein insertion. And the last question is, in case of an extravasation of a vesicant drug, the nurse should first A, apply HIT, B, remove cannula immediately, C, stop infusion, and D, massage the area. What is the answer? A is applying HIT, B is removing the cannula, C is stopping the infusion, and D is massaging the area.
C.
What answer we are getting, Sharmishta Ben?
In chat box, it's showing C.
C, stop infusion. Yeah, everyone is right over here, and they are getting a full mark for this question. Now the last one is An early sign of an IV infection is A. Fever, B. Purulent discharge over IV site, C. Redness at the insertion site, and 4. Septic shock.
C.
Sorry?
It's showing C.
C. Redness at the insertion site. Yes, so we know in a BIP score. So this is a very mild form of, phlebitis you are finding, and that is an earliest sign of an IV infection. But if you are not taking care of it properly, you may end up into the septic shock as well. And this ants here, I had a very nice slide. I hope I can see the reverse. No, reverse. No. Okay. So at last, I'm thanking all of you for listening carefully. Though there were multiple disturbances because of and technical issues, but your cooperation was very remarkable. Thank you so much, all of you. And I'm ending with my presentation over here, saying that caught by Christina first coming here. And she had seen that every nurse was drawn into nursing because of a desire to care for, to serve, and to help. And we appreciate you all nurses for taking care and being as a backbone for all of our patients. And because of you, the doctors can on you the doctors can rely upon, and the patients are improving. So thanks all of you, all nurses association. Thanks from my side and all doctor sides to you.
Thank you, ma'am.
Thank you. Thank you. Yeah.
Pooja, anything from your side for madam?
Yeah, ma'am, a couple of questions are there in the chat box and Q&A. We have a little bit of time. We can, that's a ritual that we have in Ivy Talks for the questions and answers. So there is a question which is there about the ER. So specifically when there is a question which has been mentioned in the chat box by Madhukari ma'am, that the major challenges in pediatric cannulation is being faced in the ER. So could you please tell us about the solution in terms of identifying a good vein selection and navigation, avoiding multiple pricks and fixation, and management of psychological elements of parents, specifically from the ER perspective?
Imagine.
Absolutely. So from ER, if it is there are two types of a scenario. So in ER, if the patient is extremely sick and not responding at all, if the child is actively seizing, the parental anxiety would be taken care of later. You have to go ahead and take care of an IV cannulation, and then later you explain the whole condition to the relatives later on. But at that point of time, your prime importance to put in an IV line as soon as possible and start resuscitating the child. Now, again, there are scenarios when the child would be in a shock, the child would be dehydrated, and the peripheral lines are collapsed. At that point of time, you can use the central axis. Sometimes putting central cephalic vein over the elbow is a good option, because it is again a large bore vein. And even if it is not available, then you can go ahead with the femoral axis as well. And you are not getting that, then you can go with an intraosseous needle placement. That is very easy in a pediatric age group. And in a pediatric age group, the site is also just below the knee, over the tibia. You can insert an intraosseous line, and then you can start resuscitating resuscitating the baby with the fluids. And then later, when the veins are visible, you can go ahead and putting the vein and the babies. There is an emergency scenario in a neonatal resuscitation as well. So whenever the neonate is being born, is having birth asphyxia, did not cry, and you are not, and there is no heart, no respiration. So you started giving bag and tube ventilation, bag and mask ventilation, and then you inserted a tube, but then still there is no heart. You are continuing with the chest compression, and at the point of time you want to insert a line. So at that point of time, you can use an umbilical venous catheter, putting an umbilical venous catheter, giving an adrenaline, and then resuscitating the child. These are all forms of the IV preferences you should be using in emergent situations.
That's great.
Thank you, ma'am. There's a question in the chat box. from I think it's from Odisha. Minati ma'am is there. Most of the time we are facing phlebitis during the administration of concentrated electrolytes. Suggestions from your side.
So again, ma'am, concentrated electrolytes is basically when you are giving a CRL solution or you are giving 3% NaCl solution. So for that 3% NaCl and CRL solution, I would advise that CRLs can be used as a TPN. So you make a whole TPN in which you can add a CRL. So you can use a dextrose, you can use a CRL, and then you can start with the infusions. So then, there will not be much problem. And again, dextrose, any concentration about 12.5%, you have to have an, central line in C2. Dextrose, again, if you're going more than 12.5% concentration, then your chances of phlebitis would be very high and you have to have a central access in those patients. For 3% NaCl, again, I would say that, sometimes if you are finding any phlebitis issues with 3% NaCl, changing the cannula sites would be helpful. So for 6 hours, you can give for the one limb and then again you change the cannula site. You can do like that. That is what we can offer to the patient at that point of time. Yeah. Or otherwise, when you are giving this 3% NaCl, you are expecting that the child is having severe hyponatremia or some neuronal issue. You put in a central line and give a 3% NaCl through that.
Right. I hope that satisfied the query. There is a question which has come in the DM. What it's I think the question is from very many people. It's about some techniques, some non pharmacological techniques, effective techniques to calm an anxious and uncooperative child.
Talking to the child first. Make a rapport with the child first. So when you go as a sister with the injection tray in your hand, in a pediatric patient, he is either going to cry excessively or he wants to run away from you. So don't go like that.
That's right.
Go with some toy or just go and talk to the patient for 2 to 5 minutes. Make a rapport with that kid, make him calm, and then you go ahead with an IV. You explain the procedure, if the age appropriate, patient is that, and you can explain the procedure as well. Take the baby as well into a confidence and then go ahead. So that happens in my OPD as well. If I am straightway going to examine the child, checking the chest and throat of the child is not going to be cooperative enough to check me. Okay, I'm not able to auscultate the child chest or heart. But so that I have to make a rapport with the patient, and when he is into a confidence, then we can go ahead examine the patient and giving medications to the patient. Yeah.
Thank you, ma'am. And there is a question which was in the chat box, which was related to CLAPSI bundle. So, any specific care bundles with reference to CLAPSI for pediatric ICUs? Any specific thing to be changed or added?
In general, for adult and pediatric ICU, if you want, and I will share the slide with, I will share the material with Sharmista ma'am, and she'll forward it to you. But I'll share it with you. Yeah.
Done, ma'am. With one or two more questions. They have come as DM itself. So, what is a suggestion like what is your approach to children with the history of multiple failed cannulations?
Okay. So for multiple failed cannulation, my approach is first recheck the indication of IV cannulation in that child, right? Second, so if it is like that, if the child is started taking orally, he is taking oral, foods by himself, taking, properly well hydrated, then only IV medications needs to be put in. Or if the child is when totally not taking anything, then it's an emergency to put an IV line and rehydrate the child. Then second thing is, if what is the reason for multiple, failed cannulation in the child? It's a thin vein, or what is it's a recurrent thrombophlebitis or what? So that also, gives us a clue that, okay, fine, this child is not good. Or sometimes, the patient who is requiring a prolonged antibiotic cases with an osteomyelitis. So osteomyelitis, we have to give an antibiotics for 6 weeks to those babies. So in those cases, there is no option for the except for going ahead with the central. But sometimes if the child is recovering, child is taking oral feeds well, and you are sure that the bioavailability of an oral antibiotic is equivalent to the IV antibiotics, then you can make the antibiotics orally in those kids. So you have to make sure, like, linezolid is going in the baby, and if I want to make it orally, I can make it easily because the bioavailability of an linezolid is same, whether I'm giving oral or IV. So I will switch over to the oral medications, oral antibiotics, which are covering the same spectrum of the bacteria which I want to cover in that patient, and then I can switch it over like that.
Right. I think the question is answered from your side, ma'am. That said, we have a few more questions, but I think we are overshooting time by almost more than 30 minutes now. So we'll stop the questions straight. We'll share with Shamishta ma'am and Vaman. They can come up to you, and you can come up to us with the answers. That might help. And I think we can, Shamishta ma'am, I think we can invite Ginny ma'am now to officially, for the vote of thanks. Yeah.
Yeah, first of all, thank you for the opportunity. And dear doctor, esteemed faculty members, and dear participants, on behalf of the organizing team, I take this opportunity to express our sincere gratitude to Colonel Venous Sharma ma'am, Madam Madhugar Rai, and Madam Sharmisha, and the enthusiastic Dr. Snehal Patel for delivering such an informative and engaging virtual talk on IV access in pediatrics. The session was extremely insightful and addressed one of the most challenging yet essential aspects of the pediatric care. Your clear explanation, practical tips, and emphasis on safety and confidence in handling pediatric patients have greatly enhanced our understanding. The way you connected theory with the real life clinical experience made the session both meaningful and memorable. We are also thankful for your time, dedication, and willingness to share your expertise despite your busy schedule. This session will certainly help improve our skills and confidence in pediatric IV access. We would also like to thank all the participants, those who have shared a lot of questions, their experience, for their active involvement, and the organizing team for their efforts in making this virtual program a success. Once again, thank you, Doctor, and all the dignitaries and the other participants for an excellent session. Thank you once again, and Happy New Year, all of you.
Thank you.
Thank you, ma'am.
Once again, thank you, Snehal ma'am, to accepting my invitation and deliver this fantastic session today. Thank you, ma'am.
Thank you. Bye-bye.
Thank you, ma'am. Madhukari ma'am, closing remarks from your side.
Thank you. I think we have really done due diligence in us. I have seen the doctors taking really every nitty-gritties of the facts that we do in case of we do a venous access for the child. And I was really looking at it that whether a nurse is presenting, a doctor is presenting, because all these details we generally don't find doctors presenting. So I really liked it that way it was done. And because the articles that has been really categorically said and explained very well, and the procedures also. So it is really praiseworthy. And at the same time, it is important for us to remember that once we do the cannulation, fixation is also a very important part that is a part of cannulation. So in case of children, we get scared and generally we are always apprehensive and we feel the line will come out. And that is the reason we overdo things in terms of fixation. So a simple fixation and keeping the tip of the cannula, spared for with the transparent dressing, the tip of cannula should be visible so that we can see whether any induration is there or not. Immediately we can identify. That is very important, which I see many a times missing. Then also one more thing is there that the way we do the dressing for the entire hand or leg, wherever we do channel, I have seen that the way we do dressing, we meant actually entire hand is overdressed. And because of that, what happens, we cannot make out whether swelling extra, especially infiltration happened. by the time we come to know infiltration, it is already very late. When already leg or hand is so much of swelling happens, then only we come to know. So that is the reason the fixation and the dressing has to be done perfectly and appropriately. It should not be less and it should not be more, so that we are able to observe everything end to end for the after the cannulation is done. That is also very important. I thought I must put it once in the record, because we fail to do that many a times. We are more apprehensive, line will come out. So that we should take care of. Otherwise, everything is fine. And thanks once again, Polymed, for taking this. Puja, thanks to you. Sharmishta, to you, and
Thank you,
Miss
ma'am.
Jeannie Pillai for having a great session. And congratulations to each one of you. Thank you so much.
Thank you, ma'am.
Thank you,
Thank
ma'am.
you all.
Thank you.
Thank
And
you.
Thank
yes,
you
this
so
is,
much,
as the madam
ma'am.
said, this is very difficult to handle the pediatric patient, mainly pediatric patient and their parents also. So this is a
Yeah.
wonderful session to all the nurses. At least we can get some ideas about how to tackle the parents, because more than patients, convincing the relatives part is very difficult sometimes,
No, no,
especially in the
I
vulnerable
have seen,
category.
I'll tell you, I have seen that parents are, if the parents are not well convinced before you do the cannulation, they take
Yes,
the patient on Dama from ER.
yes, yes, yes.
They say
True,
that we
true.
don't want, let us not, because child
Yes, yes,
cries
my
so
child is
much.
crying. You are making my
Yeah,
child.
so they
Yes,
cannot
yes.
tolerate.
They are
They will say
blaming
we don't
without
want.
blaming.
They will
Yes,
refuse treatment and take the child.
yes, yes.
So
Yes.
those are also challenges for us. We should
Definitely.
be keeping in mind. Yeah.
Challenges in nursing. Yes, it's a good topic.
Thank you,
Thank you.
Sharmishta, ma'am, for the wonderful topic.
Thank you, Pooja. Thank you,
Thank
ma'am.
you.
Thank you, Jenny. Thank you very much.
Thank you, ma'am.
Thank
Thank you
you.
once again. Happy New
Thank you,
Year to all of you.
everyone.
Happy
Yeah.
New
We'll
Year to
catch
all of
you.
you.
Yes,
Bye.
Happy New Year,
Thank
everyone.
you.
We'll catch you in the new year with the new
Puja is
episodes of.
already Puja is already in the mood of Happy New Year. You can see her dress.
So we'll catch up with the
Okay,
new
bye.
episodes of Ivy Talks, new
Yes, yes,
editions of
yes.
Ivy Talks, and there is a
Yeah.
big surprise
Yeah.
waiting on Ivy Nurses Day in Ivy Talks. So let's catch up there.
Yeah, fine,
Thank
fine.
you,
Surely we
Thank
will.
everyone. Bye
Happy
bye.
New Year. Bye
Okay.
bye.
Thank you.
Happy New
Thank you. Bye.
Year.
Bye. Bye.
Happy New
Bye.
Year.
Happy New Year.